Hello, everyone. My name is Dr. Vishesh Khanna, and I'm an incoming assistant professor of oncology at Oregon Health and Science University. I have the great pleasure of being joined by Dr. Amanda Nizam from the Cleveland Clinic's Taussig Cancer Institute. Dr. Nizam, thank you so much for joining me.
Thanks for having me today.
Of course. So we're at ASCO-GU here, and one of the most exciting sort of developments in ASCO-GU has been in the world of bladder cancer, which is what I'd like to ask you about today. There are plenty of now targeted alterations that we're able to take advantage of in bladder cancer, but for us in the community, how do you incorporate NGS testing into your practice?
Yeah, so the first targeted agent we saw approval in bladder cancer in the locally advanced metastatic space was Erdafitinib for FGFR, initially for FGFR2 and 3 alterations. Now the FDA approval is for just FGFR3 alterations, including mutations or fusions. Now, since there was a tumor-agnostic trial that came out, the Destiny Pan-Tumor 02, so that looked at HER2 expression in a bunch of solid tumors, including GI, and there was a cohort of about 39 patients, I believe, with urothelial cancer, with various HER2 expression levels based on IHC. That was using the GI model for IHC. So based on that, we had FDA approval, tumor-agnostic FDA approval for any patients with HER2 IHC 3+, and that includes urothelial. So that came out last year. And so now when we look at NGS testing and IHC testing in bladder cancer, so I will actually test at the onset when patients are diagnosed with locally advanced or metastatic disease. I send NGS and I also send HER2 IHC testing, preferably the IHC testing on bladder tissue or metastatic biopsy tissue if available. If patients don't have tissue available, say it was done, way in the past, or there's not enough sample to send NGS, you should always send at least liquid NGS because you want to know if those patients have targetable alterations so you can plan your treatment sequencing out. So as we know, the gold standard right now for locally advanced metastatic urothelial cancer is EV-Pembro based on the EV-302 clinical trial. That is a gold standard. There are very, very few patients that cannot get that, and really the only patients that cannot get that are if they have any contraindications to immunotherapy or if they have such severe neuropathy that they wouldn't be able to get EV. But otherwise, other patients this is the gold standard therapy. Now, since we have had those approvals of the Erdafitinib and the tumor-agnostic approval for HER2 IHC 3+ and HER2. So the question now is, how do we sequence those agents? And as we know, the perioperative setting is rapidly evolving in muscle-invasive bladder cancer. Currently, our standard of care is cisplatin-based chemotherapy, neoadjuvant chemotherapy, followed by cystectomy. With upper tract disease, sometimes we'll see upfront nephroureterectomy followed by adjuvant platinum-based chemotherapy based on the POUT trial. Now, the question is, with the Niagara data, so the Niagara was presented at ESMO 2024. This was the first perioperative trial to show an EFS and OS benefit in the perioperative space for muscle-invasive bladder cancer. We are awaiting FDA approval of that, which should be in the next couple of months. Again, this shifts the landscape. Now, what do you do with those patients who progress after that or who have recurrence after that? Because now you've seen immunotherapy. The other question is for patients who have gotten adjuvant immunotherapy. So adjuvant nivolumab from the Checkmate 274 trial, a lot of patients have been getting that even if they have or have not gotten neoadjuvant platinum-based therapy. So the question is, what do you do with those patients who are having rapid recurrences or progression after immunotherapy in the perioperative setting? And that is kind of a gray area. We don't have data on that. That's where we're going to have to really gather real-world evidence to try to fill in those spaces that we don't have data for from clinical trials. So
Understood.
Very, very rapidly evolving space. The sequencing question is still pretty challenging. In my own practice, and I would say a lot of my colleagues' practices, EV-Pembro is a gold standard. What to do after that is going to depend. You have to look at the individual patient to see what they can tolerate. In general, if they haven't seen platinum-based therapy yet, most of us would do that second line. If they don't have, if they can't tolerate platinum, if they have an FGFR3 alteration, you could consider either Erdafitinib or an FGFR3 directed clinical trial, as there are several ongoing for those, or in HER2, if they have HER2 IHC 3+ expression. So a lot of sequencing questions that are not going to be easy to answer. The other thing is we have perioperative trials that are coming out too. So at this conference, we will see a phase 2 trial from China looking at Disitamab vedotin, which targets Nectin-4 and has an MMAE payload, and then in combination with toripalimab, which is a PD-1 inhibitor. So that one had actually quite very, very impressive response rates, especially for those with HER2 IHC 3+. I'm talking about like over 80% in the HER2 IHC 3+. Again, single country data, we'll need to see the full data, but if that, becomes a player in the perioperative space now, we're looking at kind of like a Rubik's Cube for how to sequence. So there's going to be a lot of room for, real world studies to kind of fill in those gaps as we had talked about. So
fantastic. That was such a great overview of all that's new and exciting in bladder cancer. I can't thank you enough for taking the time.
Thank you so much. Yes, thank you.
Thank you all very much for joining us. We're here at the Advancements in Oncology panel, hosted by the Oncology Brothers.